move on. Any questions? Julien va analyser ça. Okay. Ready to move on in H102, 104? So there's one question about the exam. If the thoracic spine is part of the exam, what I said, everything that will be seen this week can be part of the exam. So if it's not done, osce and written. The osce, it will be the, say it this way. So everything that will be seen until the end of this week can be part of the written exam. So if we do some slight thoracic spine, you may have some slight thoracic spine that you have learned. We have not done the biomechanics. The biomechanics will not be part of the written exam. For the osce exam, if you look at the osce exam, it's actually the upper quadrant for the midterm, the lower quadrant for the midterm. So ankle, foot, knee, hip, and lumbosacral spine. So that will be the component of the midterm osce. The final osce will be the upper quadrant, thoracic, cervical, and upper extremities. Fair enough? Thank you. Okay, so we did start doing the so yes, there was a lot of question about the glides of the hip. I'm sorry, the hip section has been done a couple of weeks ago. I cannot take the sacroiliac too much time to review it, but for sure those things need to be reviewed. Don't review all those techniques the day, the week before the osce. You will be in trouble. You need to start practicing. You need to practice every week if you want to become a good physio and a good student, for sure. So we said, from my lumbar spine assessment, because we said yesterday, as I'm doing a sacroiliac, if I suspect a sacroiliac dysfunction, I will still be doing my lumbar spine scan. So we did some observation, so the subjective exam, pain type, pain pattern, mechanism of injury, pain site, as we discussed in lecture. Then we did the observation, which is part of the scan. Then you can add just looking at the scan, at the spine itself. You looked if there is any abnormal position, posture, if there is scoliosis, and you can start doing your ASIS, PSIS palpation. It's not part of the scan, but you are in that position doing some observation. It's like adding the biomechanical assessment for the sacroiliac. If you don't suspect a sacroiliac, you don't do that kind of palpation. Okay? We did, if you suspect sacroiliac, we said you can do the leg discrepancy. You can do every one of the functional tests that we said. Everything that goes, we said, with weight bearing, with jumping, upping on that leg, walking, running. We said if it's unstable, everything that goes with being uncomfortable on that leg, and having some decreased proprioception, you will be looking at those things. That has been said in lecture. Range of motion, you will be doing the same range of motion as we did for the lumbar spine. But then you will be looking if there is any pattern. Does it follow a pattern for the lumbar spine, or does it follow the pattern for the sacroiliac joint? So let's say I'm limited in extension. Let's say we are black and white. For sure, there's a lot of gray zone, but if you look at the black and white life, let's say I'm limited in extension. I've got pain on my right side. The pain is close to my sacroiliac, but a little bit higher up too. Not sure if it's the lumbar spine or the sacroiliac. I know there's a problem in extension because extension is limited, flexion is fine. If there is a problem in the lumbar spine and you suspect an extension on the right side, which side flexion should be limited and painful? At least limited.
Same side.
Same side, what does it mean?
Side flexion on the right side.
Right side flexion should be limited. So every time you're moving in extension, if it's the lumbar spine, every time you're doing an inferior glide, it will be limited. If you're limited in extension, and you suspect it's more from the iliac, it will come with a posterior rotation or an anterior rotation with extension. Posterior rotation, so which rotation should also be limited? Left rotation or right rotation? Right rotation. Which side flexion? The opposite one. So if you've got a pattern of you're limited in extension, you're limited in left side flexion, right rotation, it doesn't look like a pattern of extension on the right side. So it should ring a little bell. Oh, maybe I've got a sacroiliac joint. Yes, it may be great, and it may be something else like fascia, muscle, other problem above and below, but for the black and white life that we are in, this is things you will be looking for. Is it clear for everyone? It's the biomechanic that will guide you as you look at range of motion. That's what we were discussing in lecture. So doing it, the rollout of the lower extremities. This is all part of the scan. All part of the scan that will give you some information for the sacroiliac joint. Okay? And then we will be doing the PAs. So we will be doing palpation and PAs of the sacrum. Penses-tu que tu peux prendre cette caméra-là puis la descendre là? T'es-tu bon même? Je vais pas te mettre la pression, là. Un petit peu. Un peu de challenge. Si moi je te bouge le lit, ça aide. Jésus, bouge pas, là. Payer la tête. Souvent, on se met là. I'm just trying to see if I can have a better view for you to see the... Oui. Moi, je mets juste à toi. Just give us 2 minutes so that we can find the best. Then je vais reculer. Ben oui, je suis pas de mon côté du tout, là, mais c'est pas grave. Mais mon œil, il regarde l'autre bord, l'autre côté. Okay, palpation. So maybe, like I said on that side, remember you learn how to find your dominant eyes. There's one eye that is more dominant. So if you're doing stuff for observation, you should be on the side of your dominant eyes. So that's important. So my dominant eyes is the right side. Usually I'm always on the right side. I will be on the left side now so that you can see something, but just realize that you need to find it and use it. So we will be doing now the palpation of the sacrum. So remember what we said? Moving from the PSIS. Moving inside the PSIS, that's the sacrum. That's the base of the sacrum. We said the sacrum is an inverted triangle with the base being close to the PSIS and the apex being lower down. Tu peux me trouver un petit papier, me faire un faux triangle de sacrum, s'il vous plaît. Papier. Je te donne le papier. C'est un job à temps plein que je t'ai donné là. Non, je le sais, une chance. So we will be doing the palpation of the sacrum. So remember what we said about the sacrum. It should move in some nutation. So it will be the base, this is my wrong hand, so it will be the base moving into flexion, we call it nutation, moving anteriorly, or it can be moving into contour nutation, which is the extension of the sacrum, where the base will be moving posteriorly. Okay? So we said if you're stuck in one position, you may have This is Julien bricolage. This is the sacrum. So this is the base from the PSIS inside and the apex. So if I take it this way, let's hold the second. We suggest that Julien doesn't become an artist. And I won't be becoming a singer neither. So we're okay as a physio. So this is the sacrum. So this is the posterior aspect, this is the anterior aspect. We said a nutation it's an anterior movement of the sacrum. A contour nutation is a posterior movement of the base of the sacrum. Okay, it's always relative to the base. We said that we may have one side not moving into nutation, or one side not moving into contour nutation. We said that one side can be stuck in nutation, and one side can be stuck into contour nutation. Then we said from the biomechanics, if you are in posterior rotation, if we talk about the iliac relative to the sacrum and the sacrum relative to the iliac, when you are in posterior rotation of the iliac, you should be into nutation or contour nutation. Nutation. So that's for those of you who were there yesterday. For sure, if you were not there, you might be a bit confused. You need to go over the biomechanics. So we said, as you are moving into posterior rotation, it's the same as doing a nutation of the sacrum. So you will be looking, if one on the side that is problematic, if there is, first of all, you will be looking if both sides of the base of the sacrum are symmetrical, being at the same level, or if one side could be stuck into nutation, being deeper, like we said yesterday, or could be stuck into contour nutation, where it could be then more superficial. Okay, so let's say Jamie is having a problem on the right side. I will be looking if there's a nice symmetry of the sacrum, and then what I will be saying to all of you, that's okay, Jamie is looking at what we are doing right now, that's fine, but as you are doing those things, we do have mum stable with a little hole, and it's for your patient to have their head face in that little hole. Make sure the patient's arms are by the side. If you're all in extension with the arm above the head, you are putting a lot of tension from the fascia, from the different structure. It might change your information. Okay, always place your position in the neutral position. The headrest should be from the horizontal a little bit lower down. I saw all of you with the extension of the cervical spine, the pillow under the thoracic spine. You don't need those things. Okay? Should be flat on the table. So, and then I will be palpating PSIS. I will be moving inside, and now I need to look for is one deeper or more superficial than the other. Okay? If I look at it from here, it might not be obvious. So I need to move caudally and look from that side. And I will be looking if it's symmetrical or not. Move. So let's say that's the sacrum. Ah, tiens, je suis assez promené, je peux me promener encore un peu plus. Tu chantes encore un peu. just trying to find. So, on va essayer de me placer pour que. Oh, pas du tout, hein? On va essayer de me placer pour que quelqu'un voit, là. Merci. So, you see, I need to be looking at the spine from the side so that I can see if there is any asymmetry this way. Okay? If I'm here, it will be difficult for me to see it. So I will be looking if there is one side being higher up or more superficial or deeper than the other side. If the side that the patient is complaining of is more superficial, it could be that the sacral on that side is into contour nutation or nutation. Contour nutation. If it's deeper, it could be into nutation. We will have to do some palpation, some pressure to confirm the mobility of it. Okay? This is where I'm going. So let's say I suspect, so I need to start with a little story. So the patient is complaining of pain on the right side. I found that there was some, maybe too much contour nutation on that side. So if it's too much contour nutation on the right side, I want to see if it is stuck into contour nutation, and if I want to move, I want to move it into nutation and see if there is an hypomobility. You see where I'm going? So, more superficial on the right side, I will be assessing for stuck into contour nutation. I will be assessing for nutation mobility. What did we say? How do we assess for the mobility using a PA for mutation? We said it yesterday. So I said if you are like this, can I push on the base of the sacral on that side? Yes, I can. Okay? I cannot pull, but I can push. So I will be using the base of the sacral, and I will be doing a little pressure. It could be the same kind of handling as we said we use for the lumbar spine at the base of the sacral, looking for the neutral zone R1 or 2. You can compare from side to side for sure and see if there is any hypermobility, decreased neutral zone R1 or 2. What's the end field? I'm looking for early calcium field. So you see, I'm looking for something specific. It's too much on the superficial, too much into contour nutation. Is there a problem on that side, being not moving well into nutation? Let's say this side seems to be too deep. So it's stuck into, can be stuck into nutation. Then I said I cannot pull it. So I will be using the apex of it, we said. I'm having my sacrum, it's too deep here. So I'm having my sacrum too deep on the right side. I said I cannot pull it. That's what we said yesterday. So I will be using the contralateral apex to create that contour nutation on the right side. So I will be pressing on the apex on the left side to create a contour nutation on the right side and see if it seems to be hypo into contour nutation. So going from my PSIS, I will be moving down. I will be doing the same thing, doing a little pressure, looking for any decreased neutral zone, R1, R2. And feel. So, if we go back to everything, we said there are things there are some tests, you're looking for observation, and you're looking at it is stuck in. So every time you're looking at something, observation, you're looking, okay, maybe it is stuck in one position. So you said if you look at the ASIS, PSIS, you're looking if your sacrum is stuck into anterior or posterior rotation. If you're looking at your leg length discrepancy, it will guide you through, is it a real or an apparent leg length discrepancy? It might tell you that, oh, it's stuck into posterior or anterior rotation. As you are assessing, palpating the sacrum, if one side is deeper, you can say, oh, maybe it's stuck into nutation. If it's more superficial, maybe it's stuck into contour nutation. So this is the observation. You looked at what could be stuck into one position, and it should match. So if you found the ASIS being lower down, that more posteriorly, the ASIS being more superior on one side, on the side that is painful, is it the PSIS need also to be inferior? Okay, so you cannot have only the ASIS being superior and the PSIS being normal. Okay, so you need the ASIS, PSIS that fit, let's say, into anterior or posterior rotation. You need the if you're stuck into posterior rotation, we said it goes with the sacrum being stuck into nutation. So you should find something being stuck into posterior rotation, the sacrum being stuck into nutation. This is something you're looking for. So stuck into anterior rotation of the iliac, you're looking for is the sacrum stuck into contour nutation. So that's the first step. Then you will have to do the mobility test. Range of motion, does it fit? And PAs, does it fit with your finding? It was stuck in one position, it should be hypo in the opposite direction. And there's no way you can relate only on observation. There's no way you can relate only on palpation. It's a bunch of tests that will tell you, oh yes, I got something or not. Let's practice then PAs, palpation of the sacrum in the asymmetry, and do a little scenario in your head. And then practice doing a PAs at the base of the sacrum, at the apex of the sacrum. What are you looking for? Let's take 10 minutes, 15 minutes, have a little break. So maybe we can come